Hello, and thank you for joining this targeted oncology presentation titled Expanding Options for Treatment of Chronic Lymphocytic Leukemia Using BTK Inhibitors. In recent years, the treatment for chronic lymphocytic leukemia has evolved from standard chemoimmunotherapy approaches to strategies based on novel targeted agents. Today, we are going to talk about the expanding role of Bruton tyrosine kinase inhibitors, which are now central to the treatment of CLL. I am Dr. Jennifer Brown, Director of the CLL Center at Dana-Farber Cancer Institute in Boston, Massachusetts, and Professor of Medicine at Harvard Medical School. Joining me today is Dr. Alan Skarbnik, Director of the Lymphoproliferative Disorders Program at Novan Health in Charlotte, North Carolina. Thank you so much for joining us.
Dr. Brown, thank you so much for having me. It's a pleasure to be here, and I'm excited to discuss the role of BTK inhibition in CLL treatment.
Great. So why don't we start? We wanted to begin with the rationale for BTK inhibition in B-cell lymphomas. Do you want to start us off there, Alan? What does BTK inhibition achieve?
Sure, Jennifer. So BTK, or Bruton tyrosine kinase, is a enzyme that serves as a transducer, as a signal transducer from the B-cell receptor to the nucleus. And B cells in many lymphoproliferative disorders are addicted to B-cell receptor pathway, and they require a BTK transduction for survival, homing, and proliferation. So inhibiting this enzyme leads us to decrease proliferation of malignant B cells and decrease their survival, and also dislocate them from the lymph node compartment and allowing them to die in the peripheral blood in general. So it's a very interesting target to have in B-cell malignancies. BTK is not only found in B cells, other cells in the hematopoietic environment are dependent on BTK for growth and survival, particularly myeloid cells. BTK has a small role in activating rank in osteoclasts as well, but largely non-hematopoietic cells don't carry BTK and don't express BTK. So it's an interesting target to minimize non-target toxicities as well.
Right, and we know that also from the genetic disease where BTK is knocked out, that really the primary problem, virtually the only problem that those patients have, is related to B-cell immunodeficiency and hypogammaglobulinemia. Correct. So that was really part of how the rationale developed. And prior to the availability of BTK-targeted therapies, we know that the treatment approach for patients with CLL was largely based on initially chemotherapy, and then chemoimmunotherapy represented a significant improvement. When rituximab was added to chemotherapy, that did improve overall survival in the case of FCR. But as we'll talk about, patients with higher risk markers in particular derive significant benefit from BTK-targeted therapies.
Yes, that's correct. And not only that, as we know, patients with CLL are in general older. The average age of diagnosis is 71. It can become a little bit challenging in giving chemoimmunotherapy for older patients with additional comorbidities, particularly FCR. Bendamustine rituximab has been a regimen that's being widely used, but again, it seems that the patients with higher risk abnormalities don't fare as well in terms of long-term outcomes with these regimens.
Right, as we'll discuss, comorbidities still come into play even with our targeted agents and BTK inhibitors as well.